good morning, everyone. Hello, Carol. Can you hear us?
I can. Thank you.
Excellent. Thanks, everybody, for zooming in, and thank you to those of us in the room. We may as well get started nice and early on time. So, I would like to introduce today Anis, who's going to present his final seminar of his PhD in research. So it's lovely to get to this time point in your research when you think of years of work and study that's gone into it. It's really lovely. What we will do this morning is Anis will give us an overview of his thesis, as much as he can fit, which will take him about 30 to 40 minutes, and then we will open the floor to questions. I would like to welcome Professor Helen Edwards, who's online on Zoom, who's Anis's principal supervisor, and our panel members, Professor Carol Windsor and Professor Deborah Turner, who are also online and listening. Okay, and just to let you know, we are recording this session at the moment. So I will hand over to you, Anis.
Thank you. Good morning, everyone. My name is Anis. I am from Jordan, and this is my research topic: a mixed method investigation adherence to wearing removable cast walkers among patients with diabetes related with ulcers. I would introduce my supervisors, who are Professor Helen Edwards, the principal, Supervisor Dr. Catherine Pailison, Dr. Peter Lazzarini, also the panel members, Professor Carol Windsor and Professor D.P. Turner. This presentation will be started by background, literature review, knowledge gaps, conceptual framework, study 1, study 2, and study 3. And finally, general discussion and conclusions. We know that diabetes is an epidemic disease globally, and it's expected to reach pandemic levels by 2030. One study predicted that around 592 million people will have diabetes within the next couple decades. Now, diabetes can cause several complications, including microvascular complications and macrovascular complications. Microvascular complications such as neuropathy, nephropathy, retinopathy, macrovascular such as cardiovascular disease and peripheral arterial disease. Now, presence of neuropathy and peripheral arterial disease, or one of them, can cause what we call diabetic foot ulcers. We can see here, like, we have several types of neuropathy, such as motor neuropathy, that can lead to foot deformities and changes in the pressure distribution of the plantar of the feet. In addition, sometimes we have loss of protective sensation and changes in the skin due to autonomic neuropathy. So all of these kinds of neuropathy can cause what we call callus formation, which is hard skin located in the major pressure points related to neuropathy. So presence of callus can cause trauma of the subcutaneous tissue and then developing ulceration, which you can see here in the bottom. These ulcers are difficult to heal, and sometimes we have peripheral arterial disease makes them worse. Diabetic foot ulcers are global burden disease. A recent report from Global Burden Disease data showed that around 20 million individuals around the world had diabetic foot ulceration. Also, around 2.5 million individuals had diabetes-related lower limbs amputations. Management of diabetic foot ulcers is costly. One report from the United States showed that managing diabetic limbs complications is more costly than managing several types of cancers. Also, diabetic foot ulcers and the lower limbs amputations related to them are major independent risk factors of death, and the mortality rate of ulceration and amputations related to ulceration are sometimes higher than cancers. So to manage diabetic foot ulcers effectively, we need to reduce the plantar pressure that affect these ulceration, as these ulceration usually presented in the plantar of the feet. So there is a lot of weight-bearing pressure during walking. So we need to manage this, this what we call this is offloading treatment. We have several devices such as total contact cast, half shoes, and tilted foam like this photo, and removable cast walkers. In my research, I focused on these devices. The reason of this, because these devices are very successful offloading devices, and previous research from Gate Labs showed us that removable cast walkers and total contact cast are the most successful offloading devices that can reduce the plantar pressure for around 90% of pressure reduction. However, applying removable cast walkers in routine practice is not that effective in comparison with total contact cast. Several randomized control trials, meta-analysis showed us that total contact cast has significantly higher healing rate in comparison with removable cast walkers. Despite the effectiveness in plantar pressure reduction the same. The reason of this, because mainly we have the non-adherence issue, because they are removable, so patients don't like to wear them all the time. We have previous research showed us that patients usually wear their devices during 28 to 59% of their daily activities. Due to this issue, which is the poor adherence, these devices become the second recommended offloading option to manage diabetic foot ulcers according to the latest guidelines by the International Working Group of Diabetic Foot. So we have here total contact cast and removable cast walkers are the most successful offloading devices, but we have advantages for both of them. For instance, total contact cast is not that popular. It is only used for 1.7% of clinics in the United States, according to a previous study. And it has several disadvantages, such as it is costly, time-consuming, and can impact patients' quality of life. While removable cast walkers are much popular offloading devices because they are easy to use, clinicians can prescribe them easily. They don't need to have a lot of skills to do them because they are already prefabricated devices. But we have a lot of we have disadvantages that you see, but we have mainly the issue of poor adherence. So my research mainly aims to understand this issue, and this is really important because, as I said, these devices are popular. So we need to understand adherence. So hopefully later making them more effective devices and can be maybe the first recommended offloading devices. I started my research in my first year by doing literature review, investigating the factors that can impact adherence. And I searched in different databases, Medline, Google Scholar, Cochrane Library, and Web of Science in the last 20 years. And I used broad search terms such as offloading, removable cast walkers, and adherence. And I only found 3 studies that measured adherence to wearing these devices. From the 3 studies, only one study investigated the factors or the predictors of adherence. And this study found motor neuropathy quality of life pain associated with more adherence, and the postural stability related to motor neuropathy associated with less adherence. While the other studies didn't investigate any predictors. So this shows us that there's a gap of knowledge in terms of understanding the adherence to wearing removable cast walkers among patients with diabetic foot ulcers. Due to this gap, I did a broad search in different conditions to have more understanding of adherence in general. Then this can help me to hypothesize my research hypothesis for the aim of testing them in future. So I found factors such as patients' knowledge or beliefs were associated with adherence in different conditions such as venous leg ulcers, rheumatoid arthritis, diabetes. Also, depression was a significant factor, self-efficacy. So mainly these psychosocial factors, we have a lot of evidence to support them as predictors of adherence. In addition to the literature review, my research was guided by a conceptual framework, which is the social cognitive theory. Social cognitive theory mainly focuses on the relationship between personal cognitive factors and behavior. We have factors such as knowledge, outcome expectations, self-control, social structural factors, and self-efficacy. Self-efficacy has again been a theory by itself, which mainly explains that behavior can be human behavior that can be impacted by self-efficacy, in addition to factors such as outcome expectation and social structural factors, such as facilitators and epidemic. In addition to these personal cognitive factors, a previous conceptual framework also adapted another construct, which is personal characteristics. This framework mainly says that the characteristics of individuals can impact their behavior, such as their age, their gender, in addition to other factors. So in my research, I used mixed methods investigation adherence, including qualitative, which was the study 1, then quantitative, which were in study 2 and study 3. Study 2 was translation, reliability study, and study 3 was quantitative study. Study 1, which is the first study, was a qualitative investigation of adherence to removal cast workers. The research questions were, what was the level of adherence to wearing removal cast workers according to patients, and what were the factors that affected patients' adherence to wearing removal cast workers according to their experience, facilitators and barriers that worked against or with their adherence. So this was a qualitative study based on phenomenological approach, and the sample was 10 participants who had active diabetic foot ulcers for more than 4 weeks, and the setting was the National Center for Diabetes in Jordan, which is the biggest referral center related to diabetes and its complications. Also, Jordan University Hospital was under base of getting the participants, of recruiting the participants. Ethical approval were obtained from QUT and the research settings. The procedure, firstly, semi-structured interview guide was established, which has different questions to explore adherence, such as level of adherence, the reasons of adherence. Then once the participants were interviewed, all the interviews were recorded. After that, transcription of the interviews was done. Then back translation of all the transcripts was done. Content analysis was the methods of analysis, including coding the transcripts, then categorizing these codes, then matching the categories to form main themes. Trustworthiness was assured by all the codes were categorized by another author. Then the resulted categories were also discussed by the main researchers, the researcher, and the co-authors. The main themes categories were validated and agreed by 3 random participants. Results. Theme 1, adherence was reported with variation and inconsistency. The first category was adherence was most of the day. 80% of participants reported adherence for most of the day. They said that they were the devices in most of the time. However, non-adherence was mainly at night times. The second category was non-adherent during indoor activities. Participants said that they didn't wear the devices in activities such as sitting, sleeping, going to the toilet at night, and hygiene activities. So these are the main activities that patients didn't wear the devices. And most of them were indoors, inside the house. The last category, which is non-adherent during short weight-bearing steps or distances inside the house, most of participants, 80% of them, say that they don't wear the devices occasionally in short distances inside the house. The second theme was adherence was affected by multiple factors. This includes factors related to personal knowledge or beliefs, And I found that patients say that they believe that it's difficult for them to wear the devices in every weight-bearing steps. Also, they show that they don't understand the optimal adherence. They thought that if they wear the device most of the time, this is good adherence. However, this shows us they don't understand actually the adherence as they should wear the device in every single step. But they showed good understanding of offloading and the mechanism of offloading. Also, they showed that misbeliefs regarding the priority of treatment. They think that removable cast walker is not that priority in comparison with dressing or controlled diabetes. Also, I found factors related to severity of diabetic foot disease, such as pain, loss of sensation, postural imbalance, and wound healing. Also, factors related to social support from clinicians, from the community, from families, in addition to factors related to the usability of the offloading device. Many patients complained about the devices that they are heavy to wear, not comfortable, they were not satisfied with using these devices. So this shows us that these devices can really not that usable for patients, and this can impact their adherence. Also, these devices can impact their daily activity. As a result, also, their adherence can be impacted. Discussion of this study. This study provided us new details of non-adherence behavior. Actually, the previous research measured adherence objectively in the quantitative research, while this qualitative study showed us new details that we couldn't find in the quantitative research, such as we now exactly know which times they wear the devices and which times they don't wear, which activities exactly, and which steps exactly they don't wear the devices. And this can help us for future research to establish behavioral change interventions to focus on exactly the activities and times which they don't wear the devices. Non-adherence was mainly in indoors, and this study also showed us the complexity of the factors that can impact adherence. A lot of factors can work together and affect adherence. Beliefs was an important finding, as patients thought that if they don't wear the device in few steps inside the house, this is okay for them, they will not get harmed. But this is like misbelief, so patients are not aware exactly about the need of wearing the device in every step. And factors related to severity of diabetic foot disease. Also, factors related to the usability of the cast walkers. So this study helped me as an inductive guiding to know exactly what I need to test in the quantitative research based on these factors that I found in this study. The second study was translation and reliability study. Because in the theoretical framework guided this research, in addition to the findings from the qualitative research, both of them showed that several psychosocial factors can impact adherence, such as self-efficacy, outcome expectations, knowledge, neuropathic, party-specific quality of life, level of comfort, and other psychosocial factors. Unfortunately, we don't have valid and reliable scales in Arabic language of these scales, because my research was made in Jordan and Arabic is the main language. So there was a need to translate all of these scales into Arabic and getting valid translation, then testing reliability of translation. So mainly this study was validity and reliability, and the research setting was the same place, National Center for Diabetes in Jordan. Ethical approvals were obtained from QUT and the research settings. This study has two main phases. Phase A, which is translation process. The translation process of the scales was guided by previous valid and popular models, and mainly the models explain, and mainly the procedure was that the original English survey, which included all the scales, the original survey was translated to Arabic, two drafts through forward translation. Then these two drafts were compared and agreed by consensus of clinicians and experts, then helped us to produce one Arabic draft. Then this Arabic draft was back translated to English through two drafts. Then these two drafts were compared by by native speakers experts. Then there was a second consensus to agree one draft of English back translation, which was compared with the original English. Then the second consensus agreed the comparison between English back translation and the original English. So after getting the final translated draft, it was tested with 5 Jordanian participants to check clarity and understandability of the content of the survey. The result of translation, of the 75 items of the survey, 18 items were revised. This is an example of the richer in translation. For example, one item, I can look at my feet daily to check for cuts. The back translation showed that I can check my feet for wounds. Then the experts and the second consensus didn't agree the wounds because it's not really cuts. So then it was revised to be cracks on skins or cuts, and agreed by the second consensus. Also, some items were revised or cross-culturally adapted. This is an example. Original English, I can call my doctor. The back translation, I can tell my doctor. But this was suggested in the first forward translation by the Jordanian clinicians, as they said, I can call my doctor. It doesn't make sense for Jordanian people because they usually tell clinicians about their issues, not calling them. So it was culturally adapted to be fit with my research context. The second phase, which is testing reliability of the skills, and this was a cross-sectional study, including 2 visits to test the stability of the translated skills. In addition to test the internal consistency, 15 participants who answered the survey 2 times, and 61 participants from the main study who their data used to calculate the internal consistency of the majority of skills. Most of the scales showed good reliability. Internal consistency of most of the scales was good to excellent, and the Cronbach alpha was above than 0.7, except peripheral interpretation in patient's interpretation of a neuropathy. It was not reliable. Sorry. And the same in the agreement and stability. Most of them of the scales showed good agreement to excellent agreement, except also this scale poor to good agreement. So discussion of this study. This study provided us robust translation of the Arabic psychometric of different Arabic psychometric scales related to diabetic foot care. This study showed us evidence of reliability of the Arabic translation of the majority of the scales. The translated reliable Arabic scales can help the future research in Arabic region, and further validity and reliability testing is needed in future research. The last study, which was cross-sectional study to measure adherence to wearing removal cast focus, in addition to investigate the factors associated with adherence to wearing these offloading devices. This was multi-center cross-sectional study from 3 main research settings from Jordan, National Center for Diabetes, Jordanian Royal Medical Services, and Prince Hamza Hospital. The sample size of this study, 61 participants. All of them, they had active diabetic foot ulcers and wore the devices for more than 4 weeks. Ethical approvals were obtained from QUT ethics committee and all the research settings. These were the independent variables related to social demographic, such as age, gender, living arrangement, education, employment, income, health variables such as BMI, type of diabetes, duration of diabetes, HbA1c, comorbidities. Limb health, neuropathy was tested by Wolfram test, focusing on loss of protective sensation. Peripheral arterial disease was tested by toe Bracken index, and patients' feet were inspected to check amputations for deformities. Also variables related to ulceration, such as duration of ulcer, offloading treatment, and the characteristics of ulceration, the depth of ulceration, and the grade of ulceration. Also to that, under independent variables related to psychosocial variables which were in the study survey, such as efficacy, outcome, expectations, and other psychosocial variables. The main outcome of this research, which is adherence, was measured objectively for 1 week period of time. What I did exactly that I provided patients with 2 activity trackers. I gave them 1 activity tracker in their wrist to measure the overall activity, and I attached another activity tracker in the offloading boot. You can see here, I used Fitbit Flex, this small tracker. It was attached to the offloading boot, which helped me to measure the activity during wearing the boot. Then, also, it's important to say that patients were concealed from the main aim of using these trackers to avoid any adherence bias. Also, patients were reminded on a daily basis to wear their wrist trackers to get more accurate measurement of adherence. In addition to the objective measurement of adherence, adherence was also measured subjectively by using visual analog scale to estimate the daily steps of adherence, in addition to adherence time by using blanket questions and other visual analog scales. Adherence calculation was mainly through this Excel sheets. What I did exactly that Fitbit Flex helped me to get the number of steps in each 15 minutes timestamp. I entered all the steps that were recorded in the wrist for each 15 minutes timestamps in this Excel. Also, I entered the steps which were recorded by the cast worker in this Excel. Then I start to compare the steps in each 15 minutes timestamps that were recorded by the wrist and the cast worker. When the steps were recorded by the wrist and not recorded by the cast worker, this means this is non-adherence activity. While when we have both of them steps, when we have like steps in both for both of cast worker and the wrist, this means patients wore the devices. The adherence activity were like coded as a green units, while the non-adherence was coded as yellow unit. Then adherence was calculated by counting the green units of adherence from the overall activity, from the green and yellow activity units. The result of objective adherence was 30 patients wore their devices and only 33.6% of their recorded activity during 1 week. And this is poor adherence, not good adherence, while they self-reported high adherence. They said that they wore the devices in 70% of time, and they wear the devices in 90% of the steps. And this is a big difference between what they said and what we measured. In terms of the factors associated with adherence, firstly, all the variables which had p-value less than 0.1 were entered to multiple linear regression. Backward elimination resulted in 4 significant associated factors with adherence. Duration of diabetes negatively associated with less adherence. Heaviness of the offloading device negatively associated with less adherence. Females showed higher adherence than males, and patients with peripheral arterial disease adhered more than patients without peripheral arterial disease. Discussion of this study. This is the third study globally which measured removal of cast workers' adherence objectively. Actually, non-adherence was high in this study, which is in line with the previous adherence studies. Adherence was overestimated subjectively, and this is new evidence. Adherence was higher in outdoors. This is based on Likert question, and this is in line with the previous research which investigated adherence to preventive footwear. They found that patients wear the footwear more when they go outside. The same here in removal cast workers. So regarding discussions of the factors, longer duration of diabetes associated with this adherence, I explained this that patients with longer duration of diabetes, they have more complications, so they need to adhere to several treatments. So this can make adherence to cause walkers more complex. This is one explanation or one prediction. Also, we have evidence that longer duration of diabetes associated with depression, and depression can be associated with adherence. Unfortunately, we didn't measure depression in this study because in the previous research, they didn't find depression as predictor of adherence. Females had higher adherence than male, and this was like a common knowledge previously, as globally, females are less likely to have ulceration or amputations. Also, I explained this from the cultural perspective of Jordanian women, as Jordanian women are less likely to socialize or have regular jobs, so they don't need to be worried about the appearance of the device when they go outside. So they wore them more than males. Also, Jordanian women, they can hide the offloading device when they go outside, when they walk, while the Jordanian males, the devices, when they wear them, they are obvious. So maybe they are worried about the appearance of the devices, because I found previous evidence from the Jordanian population that usually people with a chronic disease consider their treatment, which is, when it can be obvious in front of people, they consider it as stigma. People don't like to show other people their treatment. So this could be a hypothesis that may be tested in future to know exactly what is the reason behind the difference between males and females. And patients with peripheral arterial disease had higher adherence, and this mainly because patients like I forgot to say here that this confirms that the severity of diabetic foot disease can be an important factor to predict adherence, as previous study found that neuropathy, pain, all of these factors associated with adherence. The explanation of this factor is like because patients with peripheral arterial disease are usually perceive more seriousness of their condition. And we know that peripheral arterial disease is one of the main of the major causes of lower limbs amputations in addition to osteomyelitis. So patients with this condition, they are much more worried about their feet to be amputated, so they wear the devices more than patients without peripheral arterial disease. Also, sometimes peripheral arterial disease can be associated with pain, so possibly wearing the devices can reduce the pain from this condition. Lastly, the heaviness of the devices were associated with this adherence, and this confirms the previous qualitative research which investigated self-care activities and adherence to offloading, and heaviness of the device was main themes in these two previous studies. So this is very important finding. Heaviness of the device can be very important to predict adherence. The implication of my research in social cognitive theory, actually I didn't find associations between psychosocial factors such as self-efficacy, outcome expectations, and adherence. I explained this because I think I used scales that measured self-efficacy and outcome expectations related to foot care, not specifically adherence. So this is probably the reason why I haven't got significant association, because in my qualitative study I found patients have no efficacy to adhere wearing the device in every step, and beliefs regarding this as well. But unfortunately, we don't have currently robust and valid reliable scales to measure specific psychosocial aspects related to adherence to wearing offloading devices. So we can't here refute or confirm the ability of self-efficacy theory to predict adherence to offloading. Future research is needed by using more specific and valid scales. However, this model found that social structural factors, impediment, which is here heaviness of the cast walker, were associated negatively with adherence. Also, personal characteristics was the most important predictor of or factor of adherence. We found like gender, severity of diabetic foot disease, associated with adherence. Recommendations. It's very important now for clinicians to adopt non-removable offloading devices. It's obvious now that the treatment which the Jordanian clinicians use in Jordan looks not that effective, as patients don't wear them a lot. So it's very important for these clinicians to understand that patients don't adhere to their treatment, and they need to think about non-removable offloading devices, possibly making these devices non-removable. Also, clinicians need to consider the factors that can impact adherence. Also, adherence should be measured objectively. This is very important. We found that adherence was overestimated, so we can't rely on what patients say. So even in clinical practice, future research, they should measure adherence objectively. Overestimation of adherence indicates that patients are not aware about their adherence. So this is very important, that we need like self-monitoring activity tracking of adherence to tell them exactly how much they adhere to wearing these devices. And we have recently some solutions from the industry about the smart offloading boots, which can measure adherence and provide patients feedback of the amount of adherence that they do every day. We need specific education and motivation strategies to encourage patients to wearing the devices in every weight-bearing steps, as we found lack of beliefs and loss of efficacy in the qualitative study. Offloading industry should consider heaviness of the offloading devices as a factor of adherence. Strengths of this research, this was a mixed method research using both qualitative and quantitative to understand adherence, to have a comprehensive understanding of adherence. The investigation was also guided by a popular and valid conceptual framework, which is social cognitive theory. The research used valid and reliable Arabic psychosocial scales related to diabetic disease. Adherence was measured objectively, including fulfilling the aim as recommended. Limitations: sample size was not that large because we had very restricted inclusion criteria. Patients who wore the cast walkers and have active ulceration, and also the PhD timeline is not suitable for getting larger sample size. The research only focused on remote gas walkers. It is good for future research to study other offloading devices. Cross-sectional design is not ideal to investigate the causality of the factors affecting adherence. In addition, we couldn't measure wound healing because it was only at one point of time. There was a possibility of missing adherence data during activity, as we were not sure that patients wore the risk devices with the risk trackers all the time, but they were reminded in a database. Also, some of the psychosocial measures, such as self-efficacy beliefs, were not specifically related to offloading due to the lack of the valid skills. Conclusions: adherence to remote gas walkers was poor among patients with diabetic ulcers, and this is a new evidence from different population, especially Jordan. Adherence to remote gas walkers was overestimated when explored subjectively, and this was clear from both qualitative and the survey. Adherence to gas walkers can be impacted by multiple factors such as beliefs, severity of diabetic foot disease, social support, and the usability of remote gas walkers. Adherence to remote gas walkers was associated with gender, duration of the arm, peripheral artery disease, and the heaviness of gas walker. I want to acknowledge the Commonwealth of Australia, the Australian Government Research Training Scholarship, and QUT HDR tuition fee sponsorship. I want to thank all the translators and experts who participated in study 2. I want to thank all the colleagues who facilitated my data collection in Jordan in the 3 main research settings. I want to thank also all the patients who participated in my research. Also, I want to thank all the wound HDR colleagues at IBI, QUT. I want to give this award for my father's soul, who passed away before I came here in Australia and started the PhD. I want to thank my supervising team, which I believe this work will be impossible without their advice and support. I want to thank the final seminar panel, Professor Professor P.B. Turner and Professor Carol Windsor. And I want to thank my family, and I want to give this word for them. And thank you.
Well done, Anas. That's very well done.
Thank you.
It just goes to show all the hard work that you've put in, it's got some great results there. So what I will do is we will open up questions. First we'll open up questions to the panel members who are online, and then we will open up to our other members. So I might ask Debbie